to try and use. All right, so this morning what we're going to begin to move toward is discussing provisional restoration. What is a provisional restoration? Why does that differ from a definitive restoration? And where does that fall into our clinical sequence? For our purposes here at the School of Dental Medicine, you will always be asked to make a abutment preparation and make a provisional first before you make a final impression. That is always the sequence that you will follow here. You are asked to do that because when you make your provisional restoration, you then work through any difficulties, undercuts, lack of reduction when you make the provisional restoration. So that gives you information right there relative to your abutment preparation. Okay, so that is your sequence. Yes, once you have perfected that and get a little bit more proficient with that, those particular procedures, yes, you can then proceed with making a preparation and making an impression. But here, I ask that you do it in that sequence. You will then not waste your time and waste impression material. Okay? So that is the appropriate sequence. So what is a provisional restoration? There are several types of materials that you can use. You can use an acrylic resin, and we won't utilize this until part 2, BP Fix part 2, but I want to at least go over the materials, just a review of the materials. So, and what you have before you is a composite-based material, integrity, okay? So, acrylic resin requirements. There are various types, and you will also cover this particular material when you get into your removable course, okay? So I'm not going to spend a whole lot of time there. It's the same base material, but different properties based on the function of that particular material, what we want it to do intraorally, okay? We can utilize acrylic resins for making prosthetic teeth, a denture repair, orthodontic appliances for those of you who have gone through orthodontic treatment, impression trays, base plates, which you'll cover in your removable courses, and for our purposes, provisional restorations and or maxillofacial uses for making an obturator for someone who has some type of head and neck defect, okay? They can be natural appearing, either gingival or hard tissue tooth appearing. They can be color stable and have some adhesion to plastic, metals, and porcelain. They are relatively easy to repair, a lot of process, but easily to repair, and have a economic value. So it's moderate cost. So it's very economic for us to use. For the other type of material we're going to discuss is the chemically accelerated plastics, which are supplied in various shades to match the existing dentition. It's not a perfect match because this is something that is just going to be covering the tooth in the interim while we're making the definitive restoration. So another term that is typically used outside of this class is your temporary. But we will utilize provisional restoration, right? Right? Okay. Although for some of these chemically active plastics, we do have some patients that have allergic reactions to the monomer that is present, so we try and eliminate that. And as they're setting, it does have an exothermic reaction, so if you're not very careful and monitoring the material very carefully, your patient could have an intraoral burn or you could actually burn yourself. So you've got to be mindful of that, okay? If you're not paying attention. Okay, why is it not moving? Hello. We have various chemical names here. I'm just reviewing that for now. Bless you. This is not something that you need to commit to memory for any quiz or any test for my purposes, but for part 2 of the national boards, you will have to know something about these materials. I would ask that we wait until you get to year 2 to commit most of this to memory, okay? But I'm introducing the terms to you now. So those are the three types of forms of acrylics. And they have various reactions there, and you'll also cover this in your dental materials course. Okay. So the Dr. Rizante will cover a little bit more about this in your dental materials course. March. So you get to it next month. Fun. So now you know what it is. All right. This is a particular acrylic brand. I'm just going to let that soak in. Again, this is not something that you need to commit to memory right now, but the information is there, and you'll discuss that a little bit more in your dental materials course. Then you have another form of acrylic, which you actually have in your, I think you have a like in your kit, or we'll get that in your kit next year. So that is a material that you need to become a little bit more familiar with, the properties and all of those characteristics there, versus the trim or snap, which you could also purchase, but we decided not to put that in your kits for you, okay? So there are various types of provisional restorations and manners in which you can make them. You could use a prefabricated shell that is tooth-like. You could use an aluminum shell, and this is typically utilized in a pedodontic application because it's easy to use, and that tooth for most purposes is just being there, maintained there as a space maintainer so that you do not lose arch space. What we will work on is the custom and direct techniques, because this is something that we are going to customize for our patient and do it directly in the oral cavity. And then you also have removable prosthesis, and that's something that you will cover next year in your removable courses. For our purposes, I will expose you to two different techniques. In this course, we will use a clear or BioAcryl matrix material, or today, you're going to utilize an alginate matrix material, okay? So that is something that you just a flow chart to help you understand what we're trying to do. Okay, so what I'm going to ask you to do, once you have prepared your abutment, and in your case, you need to make sure that you've had faculty feedback on abutment 30 and abutment 11. And again, your goal will be to have feedback, and then you're going to attempt to make a provisional, and we'll see how it goes. Now, I will tell you right now, making a provisional on a plastic patient with plastic material is not easy, okay? So we've gotten that out of the way. It is going to be hard. It is going to be challenging. You do not have body temperature, nor do you have saliva to help you. Vaseline as a separating medium will be your friend, even if you're adding just a little bit, okay? Because what typically tends to happen is that the material flows down and over and underneath the typodont gingiva, locks onto the simulated alveolar process, and then you begin to break your typodont, okay? So it is very important that you utilize a separating medium. More is not better. So when I show you how much material to use, I'm going to caution you that the picture that is shown is way too much, because it will flow everywhere to go into the adjacent teeth, and it'll be very difficult for you to clean that up, okay? And again, I will continue to say this, you are working on a plastic patient with plastic light cure material. It is going to be hard, okay? And as on a day like today, when the temperature is rising above 50 degrees, it's going to be even that much more challenging, okay? If we had a negative degree weather day, it would be a little bit easier. But temperature can affect what you're doing, okay? Temperature and light. So we're going to all put on our patient caps, yes, and not get frustrated with ourselves nor with the faculty, because you have to do it again and again and again. And this will be a technique that you very likely will not become comfortable with until next year. But we're going to go through it, okay? Are we ready? Don't answer at once. Are we ready?
Yeah. Yes.
All right, let's go.
Hear you.
Okay, so I asked you to get your integrity material out. and your all of your instructions and material data safety sheet. So this is a syringe system, and as you can see, it pre-mixes for you. The first thing I would ask for you to do is to take off your hub of your cartridge there, insert it into your dispensing gun, and just bleed a little bit of that. Just dispense just a less than a pea size onto a paper towel. I'm asking you to do that because this has been sitting for what? Since the fall semester, yes? So there's probably unmixed material there that you just need to get rid of before you put on your plastic tip, your mixing tip. And you always want to get in the habit of doing this because you don't know how long it's been sitting in a box or sitting in a drawer or sitting on the shelf before you put on a mixing tip, so that you don't have, old material just sitting there that is not going to set, which can be kind of a pain if it's in the patient's mouth and it's not setting. I didn't ask you to put the tip on. I simply asked you to bleed out a pea-size amount on a paper towel, and you're going to put the hub back on the cartridge. That's it. Because I doubt that any of you are ready today to begin making a provisional.
I am not ready.
You don't put stuff out in these boxes. What?
Austin.
Well, that's fun.
Austin.
Are we supposed to put it on? Are we supposed to put it on?
You want to? Put it on.
Is it going to be closed and stuff?
Yeah. I don't know how to take this cap off.
Thank you.
There you go.
Pew, 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 pew.
Turn it, twist it.
Pop it.
Now I know. Yeah.
Oh, okay. Can I put it back on?
Yeah.
Put that lock on.
Just don't pull down. Don't pull the trigger unless you're ready to fire. So this will, like, at least.
Okay, are we ready? Everybody, sit down, focus, put the gun down.
You have the wrong. Yeah, you have the wrong guy.
Place the gun on the bench top, please. Hands in the air.
Wave like this. Okay.
And we're waving them. I'm not going to say the opposite. Okay, here we go. So again, you want to make sure that you take the time to get in the habit of doing that. And you want to make sure that you wipe that tip, especially if you see lots of liquid material that is settled, so that you, once you put on your mixing tip, you have just all the same amount of material coming through that tip that is mixing, so that you have materials that's going to set appropriately in the patient's mouth. Okay, now I'm going to walk you through the technique. What is integrity material? So this is fair game. If you're going to use the material, I have the right to ask you about what it is. It is a BIS GMA composite resin formulation with minimal heat shrinkage during the setting time. Okay, so not only does it, it's a very aesthetic material, but it is has low shrinkage, so that's good to handle for us. Integrity is supplied to you in a cartridge dispense mixed through a tip, so that you do not have to hand mix. So if we're going to add, we need to add material. We do not dispense, mix it with the instrument and try and place it anywhere. That is not what we do. I will get to what you use if you need to add material. It is pre-measured so that the ratios are similar each and every time, which you do not have if you dispense without a tip and try to mix. So you don't have the exact same material. And it also, with this pre-mixing tip, is going to minimize your air bubbles. Not delete, it's just going to minimize. So you may have some air bubbles once you mix, okay? It comes in a variety of aesthetic shades, so this is something that patients really like. It doesn't match exactly, but we can get pretty darn close, okay? So here's a list of materials that you're going to need eventually. So you have them there. Step 1, you're going to fabricate a template of an unprepared tooth. You can do that on your diagnostic cast. So you're going to begin to make a provisional on tooth number 30 if you are able to get that completed today, or at least by next time, okay? You would make a template with your alginate material in a stock tray on the diagnostic cast. Or you could do this if you have a fully contoured tooth, which never typically happens, you could do that in the patient's mouth. Otherwise, if they had a fully contoured tooth, why would we be making a crown, right? For our purposes, you could, because I asked you to maintain one set of teeth that have not been prepared, correct? You could actually do this on Mr. and Mrs. Kilgore, right? So you're going to take an alginate of the unprepared tooth. That then serves as your template or your matrix. That is the item that's going to carry the integrity material to the patient's mouth to make a provisional, okay? This is a picture of showing you how utilizing a quadrant tray that you do not have. You're utilizing your full arch tray, okay, to make a template. As you do that, once you do that, it is very important for you to snip the interproximal tags because you want to allow for material to go in the interproximal areas and ease your seating of your template, okay? And make sure that after you make that, you snip the interproximal tags either with scissors or a buffalo knife. You then want to practice seating that in the patient's mouth so that you know the direction and if it's a definitive seat or not, and making sure you're covering the appropriate teeth, if that makes sense, all right? Step 2, many of you have already done this. You've loaded your cartridge system. There's a lever in the back there that allows you to move those pulleys forward and back so that you can actually lock the system in, okay? And that's pretty easy to manage. And here, step 4, I ask you just to bleed out just a small amount and get in the habit of doing that. Bleed out and wipe off, okay? Bleed out and wipe off. You're then going to take your little blue and orange mixing tip, and it has orientation grooves that should align with the cartridge. You seat the mixing tip first and then twist clockwise 90 degrees, okay, and it locks on. Now, if we can just take a look at those mixing tips that I'm sure you have right in front of you. Please note that since the material is in a cartridge and is pre-mixed, you can't gain access to any of that material that is then in the mixing tip. So that is wasted material. Can't gain access to it. So you throw it away. It's single use. You cannot reuse. If you need to use more material, you have to utilize another tip. So you only got one box and then I think one little baggie of extra tips, correct? Yes? In your kits? So as a class, you might want to consider purchasing in bulk extra tips for everyone. Contribute and purchase for everyone. It's a little bit more economical that way. Just a suggestion, unless you just want to buy your own, okay? Just a suggestion. What's going to happen is after you have prepared your abutment, you've gotten feedback and gotten it evaluated, you are then going to just fill fill the area of your prepared tooth with integrity material. Now, here we have so much material that is about to flow into the adjacent teeth. We do not want to do that for Mr. and Mrs. Kilgore. You only want to fill up to this gingival marginal 9 within your matrix or your template. That is it. Because this is a plastic material, if you fill so that it is flowing into the adjacent teeth, like it is here, that's going to flow onto your typodont and be very difficult to remove and stick to your plastic tooth. So in this instance, less is more, okay? Before you do that, you want to make sure that you have a copious amount of Vaseline on the gingiva, your abutment, and the adjacent teeth, so that if you have excess, it's easier to remove. Even if you're going to add just a little bit, we have used diamond instrumentation in a rotary high-speed handpiece to make a rough, uniform rough surface. This plastic material will stick to all of those micro grooves, okay? It will also stick to the smooth surface of your plastic tooth. So that's why the Vaseline is important. It's not, this type of lubricant is not so important intraorally for an actual patient because you have saliva that kind of helps you, okay? Or a little bit of water in actuality, so. So a little bit less material dispensed in over the area of the tooth that you have prepared, and you are going to then seat it. Again, this is way too much material. You should not see all of this excess exuding out of your matrix. Got it? Because we're only putting enough for one tooth. Less is more. Got it? Got it? Are you sure? Okay. You're going to allow this to set in the patient's mouth for at least about a minute, and then you're going to remove the matrix. Now, one or two things are going to happen. A, let go in your mind that this is going to turn out perfectly and you have to do nothing to it. That is not going to happen. It may happen once in your lifetime, maybe twice, depending on how long your dental lifetime is. But on average, that never happens. You are going to have to do some trimming and some contouring, right? Okay. So again here, we remove the matrix, and in this instance, the provisional material is adhering to the patient's mouth. It could either do that, or it stays within the template or the matrix, okay? Either way, when you do remove it, you want to work very quickly to remove excess as quickly as you can. So all of this excess needs to be removed very, very quickly, either with a cement spatula or a number 4 PKT, scissors, whatever you can do, particularly in the interproximal and adjacent teeth areas. Because once this begins to set, you're going to have a very hard time trying to get it off. At this point, after a minute, the material should have a rubbery consistency. A little bit firm, a little bit sticky, but rubbery, rubber-like, like a rubber band. Okay? And you should be able to easily tear or cut through that. When it gets to the point that is more brittle, at that point it needs to either stay on the abutment or you need to get it back into the template because it is then beginning the initial stages of setting. You're going to allow that to cure for another 4 to 5 minutes within either, again, in the template or the matrix or on the tooth. Making certain that if you're choosing to allow this to sit on the tooth, that you have cleared all of these gingival and interproximal excess material. If you don't do that, it's then going to lock onto your patient's mouth, particularly on the plastic typodont, and you will have to cut it off or break it off. Okay? So it is important to make sure that you remove excess on the adjacent tissues, the adjacent teeth, and within the gingival embrasure. Everyone can envision where that is? Otherwise, it locks in because that's an undercut area and you will not get it off. You're going to tease that out of the matrix and/or you tease it off of the patient's mouth. Here they're using treatment pliers. You may also have to identify and find your needle nose forceps to tease that off of your patient's mouth. Ultimately, this is a rough draft of what you should come up with. Something that has adequate thickness, so our reduction amount for our all-ceramic crown was 1.5, so you should have a material that's at least 1.5 to 2 millimeters in thickness, uniformly, right? So, and have excess that you're going to need to trim. If you see areas that are thin, that then indicates to you you need more reduction somewhere. Now, Let me tell you now, just because you had faculty feedback does not mean that it is perfect. You may need to go back and reduce some more. Your provisional restoration is going to tell you whether or not you have enough reduction for laboratory fabrication of a definitive restoration, which is why I asked that you do your abutment preparation and then go to making a provisional restoration. This will allow you to work through any difficulties or any problems you may have with your abutment prior to wasting material on the final impression. Okay? So that's going to direct you where you need to correct things. If the provisional restoration does not even come off your tooth and locks on, that is a strong, high indicator that you have an undercut. If you are able to get it off and on and it breaks in the same area, typically for a right-handed operator, the distal lingual aspect of number 30, that means you have an undercut in that area. You should go back to that area on your abutment and evaluate it and correct it. Okay? And as we work through this, I know that I instructed you that you could utilize a mechanical pencil to draw on the internal line angle so that you can see that internal line angle. If you can't see it and it disappears, that's an undercut, right? So we can get in the habit, let's mark up these teeth now. It's plastic. Mr. and Mrs. Kilgore is not going to mind a little lead today or throughout the course of our time here today, and so that you can see that, okay? So once we have a rough shape here, again, it's not going to turn out perfect, and yes, you will have to go through several of these. You are then going to take either a red pencil or your mechanical lead pencil and mark the finish line. Excuse me, the margin of your provisional restoration, right? You're going to mark that. You're going to mark that so that you know, I don't want to touch that, I don't want to trim it away. All right? And then we're going to proceed with trimming this. So you trim. Unlike what is shown here, this is using high-speed instrumentation. I would prefer to use your straight nose cone and your provisional trimming kit. So you need your tall provisional trimming kit, fixed provisional trimming kit, and you're going to utilize that thin acrylic burr. If someone in the front row could pull that out for me really quickly, I would really appreciate it.
Yeah, I have a different bird that I am going to bring from here.
Your lab block here, and what you're going to be utilizing is, you have a very fine, thin, red stripe burr. That is what you're going to be utilizing mostly, okay? And depending on the amount of excess, since we're just doing single units, depending on the amount of excess, you may need to use this one as well. But this will actually probably not work to your advantage, and you may actually lose your provisional, and it might fly off into space. So hold on to it. Thank you. So you're going to trim any excess, making sure that it looks like a tooth, functions like a tooth, it still has proximal contact, and it should have at least one occlusal contact, not tripod, 3-point, and excursive movement like Dr. J has gone over, but it should have some type of contact on the cusp tips. It should have proximal, both proximal contacts that you evaluate with floss. So that means you're going to need to identify your articulating paper and your forceps, and you should have floss so that we can evaluate that. You want to make sure it looks like a tooth. It should have an anatomical form. Okay, and you could utilize, I don't know that you all have composite finishing kit, but we will make do with what you have with your lab burr kit, okay? If you need to add, if in the event that you have an air bubble, typically you get an air bubble on a cusp tip or somewhere on the central fossa, or sometimes on the actual labial or lingual surfaces, you can, you can utilize composite. You should have one cartridge of flowable composite in your kit. So you need to find that. I will also supply you with little carpules of some composite to add. Again, to add, we do not dispense integrity from the cartridge, try and mix and try to add. That is not what you do. Because it is a composite-based material, we can then use regular composite to fix any areas that we need to add to. A bubble, you would need to open up that void area and then you could fill it in with composite. If your margin is not closed or sharp, you'd have to take away material so that you can add bulk back. In doing so, you need to lubricate your abutment to do that, because this is something that you do intraorally. You do not put it back in the matrix, you put it on the patient's mouth, and you add intraorally, utilizing your composite instruments, or the PKT number 4. That will work best at this point, okay? So you want to make sure you find your flowable material. I actually prefer that you use regular composite, not the flowable, because it goes everywhere. And again, because we're working on a plastic patient, the material can slip in between your typodont gingiva, go underneath the teeth, and lock on and wreak havoc for you. So please be careful with that, all right? Easier said than done. What does this look like in real life? Here we have a very aggressive all-ceramic preparation with an adequate provisional restoration. Here's that provisional restoration seated. Not so bad for provisional or temporary, right? You see that it has the appropriate anatomical form, it has the appropriate cuss tip anatomy, it has the appropriate embrasure space, it has the appropriate interproximal contacts, and occlusal contact. It should be smooth to touch, and it should mimic and be a dress rehearsal for your patient for that definitive restoration. I have heard practitioners say, well, you don't want to make the provisional so perfect because you want to make sure the patient comes back. Well, of course they're going to come back. They paid for a service. You should not give them something that is subpar or substandard to ensure that they're coming back, right? Doc, you laugh, but you know that that is what is said and people will do, right? And so what? If your patient for some reason cannot get back to see you and you're not able to deliver that restoration, you certainly don't want someone else to think, wow, what kind of, practitioner put this crap in someone's mouth. It should be just as good as a definitive restoration, okay? We do not leave rough areas to ensure that the patient's going to come back, all right? Seating the provisional, there is an evaluation process. You first evaluate the contacts, interproximal contacts first. If the interproximal contacts are too tight, then the provisional does not seat all the way. And then you would have marginal opening. So if you start looking at margins first and you have not looked at your contacts, you are not going in an appropriate sequence. You evaluate the quality of your proximal contacts. If both of your interproximal contacts are tight, pick one to adjust. Do not adjust both. Why do I say that? Typically, if you try to adjust both at the same time, you will relieve both. Trying to add back both contacts is a challenge. Yes, it can be done, but time is money and you would be wasting your time. So pick one. Typically, I would pick the one that is closest to me, the mesial contact, right? Or your other thought might be, I'm going to select the distal contact. The patient needs to be able to floss through this with ease without trapping floss, shredding floss, or breaking the floss. So the thought process with that is, I know that's in a hard place, so I want to make sure the patient can access that, right? So it might be easier for you to adjust the distal. That's, you pick what's going to work for you, right? But the quality of that contact should be that you should be able to get floss through with a snap and pull it through, not going down and up. You're going to snap through the interproximal contact and pull it through. It should not shred or snag floss. Once you've ensured that the provisional restoration is seated fully, then you can begin to evaluate marginal integrity. For working with integrity material, if we have a marginal discrepancy, because the nature of our material is brittle, it looks nice, but it is brittle. In order for you to add, you can't just add just a little bit if you have a blip or discrepancy. You need to take away material so that you can add bulk to that material so that it will stay, okay? If you're adding to correct a marginal discrepancy, you must, each and every time, apply a thin layer of Vaseline. If you do not, it will stick to the plastic tube, guaranteed. Okay? Once you have evaluated your marginal integrity, you're then going to make sure that your contour and occlusion are appropriate. It should look like a tooth. It should have the appropriate contacts. It should have the appropriate cusp tips. It should have some anatomy, the central fossa grooves, marginal ridge, all of that fun stuff. And we are only looking for cusp tip contact in MICP. No excursive evaluation for Mr. and Mrs. Kilgore, okay? But you would do that on an actual patient. Our clinical sequence, again, I cannot stress to you enough, is that here at the School of Dental Medicine, I ask that you provide an abutment preparation. You then are going to make a provisional restoration that will help you, give you feedback relative to do I have enough occlusal reduction? Do I have any undercuts? Is my finish line smooth and regular? Do I have enough finish line depth? Am I now certain that I'm ready to duplicate this and provide it to a laboratory technician so that they can make a definitive restoration for me? Once you have gone through that and worked through all of that with your provisional restoration, then and only then should you attempt a final impression, okay, which we will get into next week. So that's the appropriate sequence here at the dental school. So for today, what I'd like for you to continue to do, I'm going to provide you with another feedback form for abutment number 11. If you were successful and got good feedback and you're ready to move on to abutment number 30, you can move on to a number 11. If in the event you've gotten both of those done, I would ask that you make your matrix or template and begin to attempt a provisional restoration today. Again, the goal being by next week, you at least need to focus on having 2 abutment preparations or at least one of these completed and done and have had faculty feedback so that you are ready to have a competency practice. Okay? So we're not just attempting provisional restoration if we do not have both of the abutments done or receive some faculty feedback. Fair? But as you're waiting, because there are only 3 of us here, we lost one faculty member because there's no one else available in the clinic. There are only 3 of us here. We're going to divide up and take each section of the room. There will be some waiting time. If you want to be adventurous and attempt to make a provisional, have at it. Okay? Any questions? Silly or otherwise? Okay. Yes, sir. Hang on. Yes. You should, I should have some in the supply closet. I'll get a little packet for you, okay?